Internal Medicine Specialty Registrar in the Wales Deanery, and I have chosen to take time out to do research as a Wellcome Trust PhD doctoral fellow, and I'm halfway through this as well. So, the focus of the talk will be about specialty training in internal medicine in the UK. So the dream of the Royal College of Physicians has always been to train physicians who are experts in their specialty, but also experts in general internal medicine. And the idea is that this training will happen at the same time. And as you know, in the UK, you cannot train in general internal medicine on its own. You have to train with a subspecialty. And the idea is that you balance the training so you can be a well-rounded physician. However, the reality is different. So, for the general internal medical take, the GIM take, only 42% of consultant physicians contribute to this take. So less than half of our physicians actually look after internal medicine. And this is a stepwise decline from 61% of trainees who dual the credit in general medicine and their specialty training. The bulk of the people the bulk of the physicians who contribute to the GIM take are geriatric physicians, 20%, gastroenterologists and respiratory medicine and endocrinologists who contribute between 14 to 16%. Cardiology is guilty of only forming 5% of this specialty. So, what was the dream of a balanced training between generalism and specialism has actually, over the years, tipped more in favor of specialism. People are dropping out of general medicine from their consultant job plans, and they're doing more of their specialties. However, there's a lot of drive to change this because no one patient now comes to you with a single organ disease. Most patients will come in with chronic kidney disease, a degree of heart failure, CCF, IHD, we all see it, AF. And that means that patients are complex, and complex is becoming the new norm. And the World Health Organization has reported on the fact that we are getting more elderly patients as well coming through. So we have an aging population, and the proportion seen in the graph in the blue of patients over the age of 65 has overtaken the percentage of children under the age of 5. So we are having an aging population. And that means that we have a growing number of people with multiple comorbidities and therefore complex needs. There's also an element of health inequalities, and we also mentioned earlier about the medical legal patient expectations, which means that you need to be able to detect things outside of your specialties. And as a result of this, the Royal College and the World Health Organization have recognized that we need more doctors who are capable of providing general care in broad specialties across a range of different settings. So to address this and study it further, the General Medical Council commissioned a review of training, which builds on from what you mentioned earlier, which is called the Shape of Training. So in 2008, a committee led by Professor David Greenaway in the UK looked into how we can address these difficulties, looked into what the problem was and how we can shape the training curricula to address this. And that report looked at time for training, how we do the training, and generated its final report in 2013. And recommended that postgraduate medical training curricula must better support the needs of patients and the service, and it should produce doctors who can participate in acute, unselected takes and provide continuity of care. It also addressed issues regarding the delivery of care in the community, flexible training, and how we can deliver specialist and subspecialist components as credentials to top up general training as opposed to instead of general training. And up until a year ago, this is how the Royal College of Physicians delivered its training in medicine and medical subspecialties. So you do your medical schooling, you do your foundation training, and again, that's semantics really, because you can still do physicianly training in your foundation, you can do your MRCP in foundation as well. But then when you choose to differentiate into a physician, then you go through core medical training for 2 years, during which you acquire MRCP UK, and if you finish both of these, then you're able to progress into your higher specialist training in a subspecialty of medicine, GI, cardiology, endocrinology, and so on. Then you do your exit exam at the end of it before you become appointed as a consultant. And generally, the foundation training takes 2 years, core medical training takes 2 years, and the higher specialist training takes 5 years. So 9 years in total. But this was no longer fit for purpose. And the Joint Royal College's Physician Training Board decided to change it. And this was driven by the shape of training review that I mentioned earlier. But also, as we mentioned earlier, there's been a lot of drive for a tick box exercise. Do 3 appendectomies and you're signed off, as opposed to do the old school level of competence. And 3 appendectomies may be enough for some person, but not for every trainee. And for that reason, the GMC decided to change the way professional capabilities are assessed. And that was another driver for the Joint Royal Colleges to change training. The other thing we notice in medicine, and my consultant physicians might agree, is that there's a lot of anxiety amongst core medical trainees to take up the medical registrar role. They feel they're not ready. They feel they need more training. They have a phobia of the general medical registrar role, which is probably the most fulfilling role in the hospital. And there's also a burden of assessment, a tick box exercise, and there's not much flexibility. So as a result of this, training in physician specialty is changing. So whereas this was the old system, it stopped becoming the norm, and as of this year, training has changed. So now what they did is, you still do your medical school, you still do your foundation training, but instead of doing 2 years of SHO equivalent core medical training with MRCP, the training is now changed to a 3-year scheme called the internal medicine training. So they added an additional year onto the 2-year scheme, which I'll describe what happens with that. The idea is that they're going to deliver more of the undifferentiated general medical skills during this stage 1 of internal medicine training before moving on to specialty training. Now, of course, the people who decided to do this, they thought, that's okay, we'll just add another year from this and shorten higher specialty training by a year, which is not a good idea. Particularly in cardiology, we've refused. We said, no, we'll still do 5 years of higher specialty training, because there's no way we can get all our echoes, angios, pacemakers, ICDs, CRTs in that year. Nevertheless, this is seen as the new model. And what happens in this new scheme, the new intermediate scheme, is that you will still spend 2 years as an SHO in medicine to prepare for MRCP, but they've decided to write down exactly what you need to do. So you have to have a mandatory component of acute medicine, acute take, geriatric medicine became an obligation, everyone has to do it, outpatient experience, ITU, HDU, and of course simulation, which is now becoming the new norm. So instead of see one, do one, kill one, as you said, we have to do simulation, do 100 chest strains in simulation, and then try your first chest strain on a real patient under supervision. But perhaps core to this change is they're going to enforce a year of medical registrar onto all SHOs. So you have no choice, you have to become a medical registrar at the end of this IMT. And that will alleviate some of the anxiety, it becomes the new norm, the expectations, and it fills in a lot of the gaps that we have on the medical registrar road to as well. And then for your specialty training, the idea is now you can do less of the general medicine take, more of the specialty takes. Your training changes from a tick box exercise to a more holistic assessment with something new called the Capabilities and Competencies in Practice, CIP. And the idea is that you will replace this with a global rating, so probably almost going back to the old system. If your trainer thinks he's okay, he can do an echo, they'll tick you off as opposed to, yes, he's done 200 of this, 300 of that, even though they're suboptimal quality. To go with this, the Royal College of Physicians has decided to group their specialties into 2 groups, Group 1 and Group 2. Group 1 specialties have to dual accredit in general internal medicine alongside their training. And this includes the traditional specialties that did, endocrinology, geriatric medicine, but it also includes specialties that never had to do general medicine before, such as palliative medicine and rheumatology. So these guys will now have to contribute to the general medical take. The Group 2 specialties, such as hematology, immunology, and clinical genetics, they do not need to dual accredit, and they end up with a single specialty on the GMC register. So change is coming, and it has started. So this year saw the first intake of IMT1s. There's no more core medical training of the old style. In a couple of years' time, the IMT1, IMT2 will progress to the IMT3 medical registrar role, and there will be no further recruitment to the old school ST3. And this is unknown, the format of this remains to be determined, but it is envisioned that this will be an entry point for international medical graduates. So our colleagues from Iraq, for example, may do the MRCP, come here on the MPI scheme, and then they may be able to enter the physicianly training scheme in the 3rd year of IMT. And in 2020, we'll see the first year of the new style higher training, where you'll do fewer years and that remains to be determined. So in summary, there has been a drive to more generalist training in internal medicine. This has been heavily influenced by the Shape of Training Review, which was published in 2013, but the longer impact of these changes remains to be unknown. The dream is to rebalance the scales, such that we have a better balance between specialism and generalism. But I worry that we will tip it the other way, and we might have more generalism than specialism. But that remains to be discussed. So thank you very much, and I'll be happy to take any questions.
Just take 2 questions, Dr. Khalid.
Thank you for your talk. I am a consultant microbiologist, and I have been through many hospitals, whether teaching or DGHs. What is the most frustrating moment in your training that you can talk about it? I mean, for example, you talked about competency and you talked about system. Which one you feel that need to be changed?
Well, the system influences how quickly you acquire the competencies. So if the system says you can't do a pacing list post nights because you're too tired and you're not covered medically legally, then you can't do a pacing list, and you don't get these 3 extra pacemakers that might speed up your training. The system also doesn't allow for this. I've had to come in on my days off to do my procedures. I've had to come in on the weekend to finish my epicardiography training, possibly because I'm taking the responsibility for my own training. I think the two are interlinked. The system is breaking the competencies, and the fact that we are requiring new types of competencies, we need more of the leadership, more of the management, is forcing the system to compromise on our training.
Can I be more specific? Is it the trainer, availability when you do any procedure?
No, the trainer availability is probably better, I would say. So all the angiographies that I do, even though I do them all on my own, the trainer is, you can train them and they come in and help you with a difficult case if you need. So trainer availability is not a problem. In fact, if anything, my trainers are frustrated when I can't turn up to a list because I've been on nights the week before or I've been on a weekend. So in some ways, I think the trainers are doing their best. They always tell us about how they trained and how we should train. But in my days, I used to do 96 hours straight, etc. But I think it's becoming also the trainees. A lot of trainees are saying, no, I'm not sacrificing my day off. I'm not sacrificing. Someone mentioned the European Working Time Directive. This is not going with Brexit because it's enshrined in the UK law. So if you work extra hours, even if your trainer are happy to train you, you'll be breaking the law and you might not be covered medically legally. It's difficult. Yeah?
Social care and that medical care these days on the agenda of the agenda. Is there any role for the for the training and for the social care in order to amalgamate the things and focus on patient problem, which is, as you say, is a complex problem?
It is a complex problem, and I think the new curriculum is trying to implement this. So there's going to be a focus on delivering care in the community. We're already seeing a lot of schemes going into more community-focused hospital medicine. So the frailty schemes, for example, a lot of geriatric physicians who normally would practice in the hospital are now practicing more in the community. As I mentioned earlier in the IMT curriculum, what we're going to see is we're going to see more of the community-driven care I mentioned earlier, so that we can deliver care to the patient's bedside. But capacity remains an issue. So a lot of places don't have the right amount of physios, right amount of occupational therapists, right amount of specialty doctors to deliver this, but it's on the agenda. How it gets implemented is a different question, I think.
Last question with the Fawzi.
Majid, I think one of the reasons that the generalism nowadays is getting more. We are the tertiary hospital. We do have consultants. They come, they are very good in cardiology or whatever, but in general medicine they are not very competent. They always ask, we are tertiary hospital, we don't have GI or respiratory. So for whatever simple reason they do ask somebody in GI or DC. I think generalization is very important before the specialization.
Yeah, I agree, as long as it doesn't compromise your specialization.
Yes, well, unless they give you an extra year, which is too much.
Yeah, that's predominantly it, but we'll see. I'm positive about this. I'm doing general internal medicine still, but we'll see how things pan out over the next 5 years.
Thank you.